Okay, thank you, Raman. All right, moving along, I'm going to give the second talk of this section on management of eosinophilic esophagitis, role of diet medications and endoscopic approach. I have no financial conflicts. So we'll talk a little bit about the background of EOE and then talk about the case for and against each of the options that I mentioned. So this is a clinical pathologic diagnosis, and by that you have to have symptoms of esophageal dysfunction, so usually dysphagia, and you need to have histologic assessment, so a threshold of at least 15 eosinophils per high-powered field that's isolated to the esophagus and persists after a trial of PPI. Biopsies should be taken from more than one level of the esophagus to show that it's more of a diffuse disease. And you want to exclude secondary causes of eosinophilia. What secondary causes? They're on the right there. Most commonly, though, we see reflux, and that's what can make this a little bit of a difficult disorder to clearly diagnose on initial evaluation. The rest are listed there. I won't go through them in detail. So endoscopic features, well, you have your typical rings, concentric rings along the length of the esophagus, either a more corrugated appearance or the one on the right that looks like you're in the trachea, but I assure you this is the esophagus. Then you have the linear furrows going down the esophagus, much more evident in the panel on the right. White exudates, which correspond to superficial layering of the eosinophils. And then this is an image of a narrow caliber esophagus, meaning that the entire length of the esophagus has been diminished in diameter. With histologic findings, again, at least 15 EOs per high-powered field. Commonly, you'll see lamina propria fibrosis, basal zone hyperplasia, which means that that bottom half of the mucosal biopsy there where you see all the dark cells, normally that should be less than 20%. In this case, you can see it's about 50%. Dilated intercellular spaces, eosinophil microabscesses, which you can see at the top of the biopsy specimen, and layering as well at the top. So the problem is none of these features are pathognomonic for EOE, so that's why you have to take other things into consideration, including response to PPI trial. So how many biopsies to take? Well, the more you take, the better the sensitivity. As I mentioned, you want to take it from at least 2 levels. Reflux tends to have more of a distal predominance when eosinophils are present, so if you see it also in the proximal esophagus, it's more suggestive of EOE. If you take 5 or more biopsies, the sensitivity approaches 100%, so typically I will take at least 3 from the distal and 3 from the mid to proximal esophagus. There may be a role for actually targeting the biopsies. There was a study that showed that furrows and white spots tend to have a higher eosinophil density than just the concentric rings, which are not necessarily associated with active disease. So these aren't audience response questions, but just something to get you thinking as we go through the management options. The first case is a 28-year-old woman who has solid food dysphagia on average once a week. This is her endoscopic appearance. And of note, she has already documented anaphylaxis to dairy, meaning that in terms of food triggers, probably dairy is not the one causing it. Second case, we have a 17-year-old girl who has solid food dysphagia for a couple times a month, Pretty classic appearance esophagus. And she comes with her mother, being a minor, and the mother is very anxious about her having to take medications potentially for the rest of her life. And then the final case, a 39-year-old man who had a recent food impaction. So this was the guy who had the trachealization, and the picture on the right is his distal esophagus, where it really looks almost like a pinhole esophagogastric junction, and you can see these pulsion diverticula surrounding the lumen. So he was dilated up to 10 millimeters in that one session, and then I didn't see him again for over a year. He said he was actually getting dehydrated because all he was eating were burgers, but then he came back to see me when the dysphagia returned. So he was actually doing pretty well at 10 millimeters symptomatically. So very different presentation and different concerns going forward with treatment options. So let's talk about medications. So before we get really into the medications, I just want to talk about this concept of PPI-responsive esophageal eosinophilia, which in previous guidelines has been considered a separate condition. So I say if it looks like a duck and quacks like a duck, but this is where it's actually something different. And the reason why I say it's all foul to me is because I still think that this is part of a bigger spectrum of esophageal eosinophilic disorders. So what are the features of PPI-REE? Well, you have the symptoms of EOE, you have the endoscopic findings of EOE, you have more than 15 eosinophils per high-powered field at more than one level, but you get better with a PPI. So that's really the only difference. And in the landmark study back in 2011 that brought this concept to light, a third of patients who responded to PPI actually had a normal pH study. So it raised the possibility that maybe there's some kind of an anti-inflammatory effect regarding PPIs that actually was consistent with some in vitro studies looking at that as well. So how do you diagnose this specific condition or subset of EOE? So you start with a PPI. The literature suggests that you should actually do it twice a day, whether it's low, like over-the-counter dose or prescription strength dose. It doesn't seem to matter, and do it for 8 weeks. Some retrospective studies looked at the 1 to 2 times a day, but experts agree that it should be twice a day to start. And then you repeat the endoscopy 2 months later, and if you still have symptoms and still have eosinophilia, then you have the more classic form of EOE. And if you respond, then either this is reflux, just kind of manifesting itself more like EOE, or it's this special consideration. But then there's no real guideline that says what to do afterwards. There was a study prospectively following patients who then tapered the dose of the omeprazole, and they found that after 2 months of once-a-day therapy, 81% were still in remission. So in light of all the concerns that get brought up about PPI safety, which I could debate with you separately, it's really best to try to use the lowest dose that's effective to maintain remission. Should patients get pH testing? Well, there was a prospective study that was used pH testing to see if it would guide therapy, and in 51 patients who had esophageal eosinophilia, 37% had a positive pH test, were put on Nexium, 63% were put on budesonide because of a negative pH test, and they found that Nexium patients had 61% histologic response, whereas the viscous budesonide patients had 57%. So there was a lot of overlap in terms of what was expected to be the outcome, and other studies have suggested that patients who even have negative pH studies still can get treated with PPI, and that's why the guidelines for the most part recommend a PPI trial first. So just to finalize the talk about the PPI responsive subset, the guidelines from 2013 in ACG suggest that this is a separate condition, but there's a more recent European guideline that says that it's probably part of a spectrum. And there was a small case series of patients who responded to PPIs and food elimination diet at separate time points. So just because you respond to PPI doesn't mean another therapy won't work. And then finally, a randomized control trial or trials of esomeprazole and swallowed fluticasone showed no difference in clinical or histologic response. I couldn't find anything that looked at crossover to see if these patients responded to one and the other, but that's just what's out there. So now we'll move on to steroids. The typical steroid that's most commonly used is fluticasone as an inhaler, but you swallow it, and it's 220 micrograms per puff, and you swallow 2 puffs twice a day. There's another option in the literature for people who this is not covered, and that's beclomethasone. The near equivalent would be 80 micrograms per puff, although there's no literature supporting this being used regularly. Best time to take it is after a meal or before bedtime because you want to prolong the time that the medication is in contact with the esophagus. If you're going to eat afterwards, you want to eat or drink something at least 30 minutes later to give enough contact time. I recommend to all my patients to, after administering the medication, even right away, they can take a little water, swish it in their mouth, gargle, and then spit it out. And to this day, I still have not had a case of oral thrush. So do steroids work? Well, they've been shown to improve eosinophilic inflammation in mucosal biopsies. And there was one study that actually suggested that it improves mucosal integrity, increasing the impedance, so there was less potential for flux of ions across the esophageal mucosa, reduced cytokines, and there was increased expression of the barrier proteins, excuse me. It's been shown to improve dysphagia, although there is some variability in the studies, the results from the studies. It might reduce fibrosis in the lamina propria, and it does seem to reduce the risk of food impactions requiring endoscopy. So on the whole, I would say yes, they work. But there are problems potentially with steroids. So as I mentioned, oral thrush, it's been reported in 1% of cases in the literature. Esophageal candidiasis is much higher, but tends to be asymptomatic and only really found on follow-up endoscopy in the research setting. Adrenal insufficiency is actually quite uncommon. In one study of children, 10% who were treated for more than 6 months with the high dose of fluticasone showed some degree of adrenal insufficiency, but this has never been shown in adults. So we don't want to usually keep patients on steroids, but with this local acting steroid, there may be a role for maintenance dosing. So the best patients to use this in are those who have frequent relapses, who have significant stricturing, requiring multiple dilations, full-on narrow caliber esophagus, prior food impactions, severe symptoms, patient preference as well. The dosing that's typically recommended is half the amount, so it could be fluticasone 1 puff twice a day, or you could consider 2 puffs once a day, which I think from compliance is a lot better. We'll move on to elimination diets. These have been very effective in the pediatric population. Almost everyone responds, although it's not quite so robust in adults, where the histologic improvement is maybe about 70% and hasn't actually been all that positive in terms of symptom improvement, probably because we have acquired taste. It's hard to go back to something of a more elemental nature. That's where the 6-food elimination diet comes in, and the pictures will cycle through all the food groups. So wheat, dairy, nuts, soy, eggs, and seafood. And in using a 6-week 6-food elimination diet, 70 to 75% had histologic response and very good improvement in dysphagia scores. And then you would reintroduce one food every 2 weeks, and in the studies they would scope these patients and take biopsies. And in the patients who underwent the repeat scopes, they actually were able to identify the trigger or triggers, with wheat and dairy being the most common. Some patients, though, had multiple food triggers. That's kind of tough, 6 foods. And, wheat seems to be found in everything. So over the years, there have been less restrictive diets that have been suggested, such as the 4-food elimination diet, which has a lower but still pretty decent response rate. And most recently, the 2-food elimination diet. As I mentioned, wheat and dairy tend to be the biggest triggers, and there was a 43% response rate. So you might consider working with your dietitian to help guide these patients in terms of the food elimination if they're committed to doing it. So why do the elimination diets? Well, most often this occurs in young people, and so consider it more of a lifestyle change, and especially in people who are really hesitant to take medications potentially for the rest of their life. And it is an option for those who don't respond sufficiently to topical steroids. But remission seems to last only as long as the diet is followed. Variability in how frequent patients have symptoms. So if you're only having 2 episodes a month, it may take a longer time in terms of the reintroduction period to see if you can identify which foods were causing the problem. This does have an impact on quality of life for patients who have very active social life or do a lot of traveling, and being able to ensure that they're getting the foods that don't have these triggers. And if multiple food allergies or food triggers are documented, it may not be feasible for some. So it really requires a commitment and an understanding of what the patient has to think about. Okay, finally we'll talk about endoscopy, specifically dilation. So I want to talk a little bit about the technique. You can either use balloon dilation or bougie. You want to identify the area of maximal narrowing, and then you want to dilate until you get resistance or blood, and then you really don't want to persist more on that occasion. This is not like a peptic stricture or just a simple Schottky ring. There is potential eosinophilic involvement in the muscle layers, and it's just a lot more brittle. You have a higher risk of perforation, or at least microperforation. Overall, though, you do want to get to a goal diameter of 15 to 18 millimeters, and this might require multiple sessions depending on the starting point. So this is just a video showing a technique she was a 50-some-odd-year-old lady who had history of several food impactions. This is actually in the proximal esophagus. We're using a standard diagnostic scope which has a diameter of about 10 millimeters, and so carefully passing a wire-guided balloon across the stricture, and you have to make sure that you don't encounter any resistance. So if you feel like you can't pass the catheter down, or paradoxically the scope moves backward, you need to readjust. Slowly inflate the balloon, so your tech or nurse who is inflating, this is not a fast dilation. You go too quickly, that's where you can cause problems. A slow stretching, you'll even be able to see sometimes through the balloon the mucosa separating, and you might see some heme present. So we dilated the first part, and I'm able to get through, and then I'll come back here, and you can see in the 3 o'clock position approximately, there's a mucosal tear. So we got past, I'm pulling back, and just on the right, there is the mucosal tear. And then we go down a little bit further, encounter mid-esophageal stricture. And again, using the same technique, slowly passing the catheter as it goes through, making sure you're not encountering any resistance. I will say one thing as the video is progressing, some of these newer scopes tend to have a little bit sharper edges, and you may find that even though the caliber of the scope is about 10 millimeters, even if you dilate up to 12 millimeters, you're not able to get these scopes through. Some of the older generation scopes have a little bit rounder edges, and it's a little bit easier to pass through. So after this one gets dilated, we'll move along. And in this case, the mucosal tear will be in about the 9 o'clock position. Surprisingly, though, with no blood. But minimal blood, excuse me. All right, so that's that. So is there a better way to, or better dilator type? So there's actually no head-to-head studies looking at balloon versus bougie, and no difference in the complication rate based on the literature. To me, the advantages of balloon are that you can see what you're doing. It has the capacity for 3 sizes, so if you don't necessarily encounter any resistance, you don't have to keep pulling out, pushing back in. The advantages of the bougie are they can be used in very tight strictures. So if you can only pass the noodle scope, you can at least pass a wire down, and then you can do the bougie dilation. You can't pass a balloon through these noodle scopes. People will say that they have a better tactile sense because they're the ones passing the bougie down, so they can sense when they feel the resistance, and that can be helpful to knowing when to stop. Can you just dilate it as needed and not worry about medical therapy? Well, the downside is that it doesn't treat the underlying inflammation, but is that necessarily what we need to achieve? I mean, it kind of makes sense that we should, but this is not a pre-malignant condition, and there are studies that show that if you get patients to above a 15 millimeter diameter and then just dilate on an as-needed basis for symptom recurrence, the mean time between dilations could be 1 to 2 years. So think of that compared to taking a medication potentially every day. May or may not help some patients. They just may not want to do that. I want to talk a little bit about food impaction and removal of the foreign body. So there's been a rise in EOE-associated food impaction, as you can see across the years, going up to about 1/3 of cases. And food impaction in EOE is associated with an increased complication rate, including aspiration and perforation. So just to talk about dealing with these food impactions, so it is an urgent indication, should be taken care of within 24 hours of the time of food impaction. It improves the chance of removal and decreases the risk of complication. It needs to be considered emergent if they can't manage their secretions, and you need to think about airway management in these patients. Pretty much everyone nowadays, at least at UCLA, is getting intubated for these procedures, because sometimes we're having to go in and out with the scope multiple times, whether or not we use an overtube, and I'll talk about that in a moment. A lot of these patients tend to have proximal esophageal impactions. The objects can be difficult to remove. If you've encountered shredded chicken, it's a real pain, and you know what. And as I mentioned, multiple passes. Glucagon, it's always a good thing to consider, especially in the middle of the night. It acts as a smooth muscle. It acts on smooth muscle, relaxing the distal esophagus and the lower sphincter. Its efficacy is controversial, and it actually doesn't seem to have a benefit in EOE, but it's a pretty safe option, so why not give it a try? Maybe it gives you a chance to wake up a little bit before you have to hurry in, but really don't plan on going back to sleep, because you're probably still going to have to deal with it. You want to have a number of tools available for dealing with food impactions, including the grasping forceps, an overtube, snare, Rothnet, and grasper. So the initial approach, it's actually suggested in dealing with food impactions that you could try some gentle pressure to see if you can advance the bolus, but it really has to be gentle. The downside is you can potentially impact it further. If you're unsuccessful, you want to try piecemeal removal, and then maybe reattempt gentle pressure. You want to be careful about dilating these patients at the time, because the mucosa is going to be much more friable from the prolonged contact and pressure of the food bolus. You can take biopsies, but just don't do it at the site where the bolus was impacted. And you really want to avoid an overtube until you know what the anatomy looks like, because if you come across a stricture and you've passed this overtube and you slide it over the scope, you can really cause some damage. What's the risk of perforation? Well, some early studies suggested a higher risk compared to standard endoscopy, about 1%, and so it was actually recommended initially not to dilate these patients with EOE, but that's probably because they were using that rule of threes, which again I'm recommending against. More recent studies suggest that the risk is closer to that with a standard endoscopy. No evidence of one dilator having a higher risk, and you can even get perforations even if you don't use a dilation. So just keep that in mind. Boerhaave syndrome has been associated with EOE and food impaction. How do you deal with perforations? Well, conservative management is certainly an option. NPO, IV fluids, antibiotic, particularly if you get one of these micro-perfs where you have pneumomediastinum but no evidence of liquid leak. Surgery can be used for closure of the perforation or esophagectomy in the most extreme case. Endoscopic options are available. Hemoclips can be tried. There was one case report, but it failed and went to esophagectomy, because again, you're dealing with a lot of fibrosis. It may not stay. Fully covered metal stents can be tried. Partially covered tends to cause tissue ingrowth. Whether there's a role for the over-the-scope clip, I have not seen used yet. So in the end, what's the best option? Well, like most things, you want to individualize therapy. If you have someone who's on the younger side is committed to lifestyle change, consider the food elimination diet. I highly recommend working with your dietitian. Ours are great, and so I really rely on them in terms of helping to provide sound dietary advice. For patients with frequent relapses, you really want to consider maintenance topical steroids and maybe a food elimination diet. And then for those who have the fibrostenotic phenotype, I consider dilation early. It will really provide symptom relief and help them out. Consider maintenance steroids, especially if you have someone with a tight stricture, you're going to have to dilate multiple times. I look at steroids as something that helps to soften the stricture and makes it easier as you dilate further. Thank you very much.